Hey folks, Scott Weingart here, and this is an EMCrit we. Now, despite this being a we, I'm still giving continuing medical education credit for this episode to the EMCrit team members because I was not able to do it for that Surviving Sepsis campaign episode due to conflicts of interest by the lead author. So check out your CME area to get credit for this episode. What we're going to be talking about today is more on dizziness and vertigo. Essentially, the title is, you don't understand dizziness and vertigo, but you need to. Otherwise, your patients are at risk. Now, what spurred this episode is I did a segment on EMRAP. Some things were said on EMRAP that I didn't necessarily agree with, or I wanted to give a little bit more context and understanding, and I recorded a segment with my buddy, Swami Nathan. And I thought it was really important stuff, so I wanted to get it out here. And it will actually come out here before it comes out on EMRAP. I try not to leave too much overlap, but this one was actually crucial, I think, that people understand, because there's been some new decision rules put out that I think if you use them, you're potentially putting yourself and your patients at harm. Okay, so we are bad at dizziness. Now, I have many papers to support that contention, but I'll just mention one of them here. And this is the diagnostic accuracy of the HINTS exam in an emergency department, a retrospective chart review. And this is pretty hysterical. 97% of the patients did not meet criteria for receiving the test as described, meaning that it wasn't even that they did the HINTS wrong, and they probably did, but they were doing it in the wrong patients. Now, either case, doing it wrong or doing it in the wrong patients really has a chance to send you astray and do either an unnecessary workup, which would be bad and a waste of resources, waste of time for your patient, or the wrong workup, which might actually cause you to miss a life-threatening illness. So this is just, it's deplorable. In many cases, patients receive both the HINTS exam and the Dix-Hallpike exam. There's no situation in which doing both of those makes sense. And they didn't identify a single case of dizziness from central cause. So it's not a great state of affairs. Now, when I was discussing this with Swami Nathan on EMRAP, he said his policy or his clinical pathway is that if the patient has spontaneous nystagmus, he just calls neuro. Now, honestly, it's not the worst thing in the world, but it's not a great way to go, because most of those patients who have spontaneous continuous nystagmus are just going to be vestibular neuritis, a benign cause of dizziness and vertigo. And only a very small percentage of those patients will actually be posterior stroke. So you're really making your neuroservice work. Now, he's not just saying dizzy equals neuro, so it's not a horrible state of affairs. He's actually taking the time to figure out whether the patient has spontaneous nystagmus or not. But we could do better. Now, the way to do better, unfortunately, is not the new risk score on the block, the Sudbury risk score. Sudbury risk score has been derived and then validated again in a multi-center retrospective, and I have the citations in the show notes, obviously. But this is a score that asks you for stroke risk factors, things like being male, age greater than 65, diabetes, and hypertension. It asks for the presence of neurological deficits, motor and sensory or cerebellar, and it asks you for a BPPV diagnosis. And all of them, except for the BPPV, have various positive point scores, and BPPV diagnosis has a -5 point score. If you are 4 or less, then you are safe from a central cause of the patient's dizziness or vertigo. Sounds good, right? That's a pretty good deal. Just a quick score and you're done. Sensitivity of 100% and specificity of 72%. Those numbers are astoundingly good. Sensitivity of 100%, I'll take that all day long. But as always, the devil is in the details. I need you to think about the Sudbury risk score like you do a BNP. BNP, when it first came out, had great test characteristics. But then when you actually looked at the population they were evaluating it on, they were patients who either had no chance of having CHF, or they were so obviously acute pulmonary edema that the janitor walking by would say, I think that patient probably has some pulmonary edema. That is not the way you need to evaluate a test. You need to give it the hard edge cases and see how it does. And BNP initially, that wasn't done, and it had fantastic test characteristics for diagnosing CHF as the cause of the patient's shortness of breath. Now, as soon as the study was published, and I believe it was in Academic Emergency Medicine, actually eliminating the clear cases on either end and just looking at the gray, which is obviously where we're going to be sending the test in the first place, BMP was horrible, horrible. That's what the Sudbury risk score is. You need to understand what's going on here. So here are the problems of the Sudbury risk score. If a patient has a new neurological deficit, motor and sensory or cerebellar, you're done. Like, you don't need a risk score. Those patients should get a workup, whether that means MRI or neuro or both. And MRI is probably not enough. A posterior stroke in its acute phase is not going to show up on MRI. So if you don't know what you're doing, then you better either get the patient to a neuro professional or call one. So I don't understand why neurodeficits are even a part of the Sudbury risk score. It makes no sense. Those patients should have been excluded, or they should have just been a multi-step pathway. And step one is screen for neurological deficits. And if they have it, don't go any further. Like, you're done. So those patients shouldn't have been evaluated in the characteristics for the test. And the fact that they did automatically means that it's going to be looking good on its specificity. Then they include BPPV. And the thing about BPPV is, if you diagnose that, if you know what you're doing and you diagnose BPPV, they don't have a central cause. That's it. You're done. So those patients should have been excluded as well, because they're not giving you any magic to diagnose BPPV. You still need to have all of the subject matter knowledge in order to make that diagnosis. And so what this risk score essentially is, it's taking in all of the patients who are clearly a central cause, new neurodeficit, you're done. And it's taking in all of the patients who have BPPV, which is the lion's share of patients who present to the emergency department with vertigo. And you don't need a risk score. That just diagnosing it is enough in and of itself to exclude a central cause. So as a result, the test is not actually being tested. And until it's tested, until they actually strip out the BPPV and the neurodeficits, we'll never know if this test has any utility at all. Now, it gets worse. Let's say the patient had a new neurodeficit or cerebellar findings, but you think they have BPPV, right? So new neurodeficit, but you think they have BPPV. By the scoring, those patients would be ruled out. New neurodeficit ruled out by the Sudbury risk score. That makes no sense. Don't use it. It's not going to help you. As we get into the weeds, we could see even more of where this risk score is going to fail. So ataxia and an ataxic gait is a sign that should be present with vestibular neuritis. It's actually part of the acute phase of this. If the patient comes in early on with their vestibular neuritis at the stage they still have nystagmus, we expect to have a slightly ataxic gait. It's expected. And that's why in our workups, we actually say, can the patient walk unaided? Not do they have a pristine gait. If they have nystagmus, the expectation is that their gait will be a little bit ataxic. And so we ask, can they actually sit up and then walk unaided? Based on the Sudbury risk score, that ataxic gait that we expect in the benign cause of vertigo with continuous nystagmus, vestibular neuritis, would actually score for a new cerebellar neurological deficit and would actually now have you doing an entire workup on the patient. So it fails that way too. So can you take anything from the Sudbury risk score? Okay, here's what I would say. And for anyone who has any dizziness knowledge, this is already going to be obviated. But if you have no dizziness knowledge, if you have no dizziness skill set, then if you have a patient who has hypertension plus 2 or more of male sex greater than 65 years old or diabetes, so 2 or more of those, then you might just want to say, do what Swami Nathan was saying and just call neuro on all of those patients. Any patient who comes in with dizziness and vertigo, who's hypertensive, and then either 2 or more of male, old, or diabetic, just call neuro. It wouldn't be the worst thing in the world if that was your paradigm. You know, that you're starting to get into a group where just working them up empirically isn't the worst thing in the world. So that's all I could say you could take from the Sudbury risk score. In every other case, it doesn't help you at all above the appropriate initial screening. Now, this is from our spin class, and I put an infographic in on the show notes for this episode. But every patient who comes in with vertigo and dizziness, before you start parsing out, could this be BPPV? Is this vestibular neuritis? Is this a posterior stroke? Is this a migraine? You want to screen these patients for the real harbingers of central cause. So we're going to find out if, along with their dizziness and vertigo, they have a new significant headache or neck pain. That's a red flag for things like cerebrovascular dissection and things like that. Do they have new focal weakness or sensory deficit? As mentioned, like if they have that, stop. Do not advance. Do not go to the Sudbury risk score. You're done. Work them up. All right. Do they have vertical nystagmus? Do they have an inability to walk unaided? As I mentioned, if they have nystagmus, then it's can they walk unaided. They don't need someone else supporting them. And if they can, then you could go further and continue your workup. If they can't even walk unaided, or they can't even sit up in the stretcher unaided, then just work them up for essential cause. Now, if they don't have nystagmus, then any gait abnormality should prompt a workup. Any gait abnormality from their baseline in the absence of nystagmus should prompt a workup. All right, and then last, you screen for the dangerous or deadly Ds, and that's diplopia, double vision, dysarthria, which is slurred speech, dysmetria, lack of coordination, probably best tested with finger to nose, dysphonia, which is a hoarse voice, and dysphagia, trouble swallowing. So if they have any of these things, stop and work them up for essential cause. So I do not think the Sudbury risk score is good. I don't quite understand. And my partner in crime in all things vertigo, Peter Johns, was on it, the paper, and so I've not ribbed him about this risk score. But the other people on this paper are brilliant people, like some of the smartest people in vertigo and in emergency medicine decision rules, like brilliant folks. So if anyone on the risk score is listening, explain to me, what am I missing? Did I get something wrong? Am I just not understanding? Am I thick? Because this risk score makes no sense to me. Let's take out the neurodeficits. Let's take out the BPPV, and let's find a new derivation of the Sudbury risk score part 2 or second iteration that actually will now screen all of the remaining things in that derivation set to find what helps me once I've stripped off the amazingly obvious neurodeficit ones and the amazingly done BPPV patients. Help me out here. All right, let's talk standing protocol. The standing protocol is better, markedly better than Sudbury risk score. It's still not perfect, and I'll tell you the reasons why, but it's pretty good. And if you just need a flow chart, it's not the worst thing in the world. Now, for our vertigo course, I made a flow chart. Hey folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening. And to get it really good requires, it's a 2-page flowchart with numerous branch points, and you wind up being capable of diagnosing posterior canal BPPV, horizontal or anterior canal BPPV, central positional vertigo. That should petrify you, right? Central positional vertigo. If you don't know what that is, be scared. Vestibular neuritis, posterior stroke, vestibular migraine, posterior TIA. Yeah, there's posterior TIA. Possible cardiac causes. And the vestibular migraine that I mentioned, that one's missed all the time, and standing doesn't address that. But let's go back and let me walk you through the standing protocol. So the first thing it asks you to do is their nystagmus, and it asks you to use Frenzel lenses, which are these like crazy goggles that magnify the patient's eyes. They prevent the patient from being able to fixate, and they magnify your ability to look at their eyes. Most of us in the States don't have access to these. When I spoke to Peter about it, he says he doesn't even think they're really necessary. They're more prevalent in Europe, but they're asking you to use them. We'll talk in a sec whether that's necessary or not. So you look for nystagmus. If the patient has positional nystagmus, meaning that it's not there, but it's only there with head movement. Then they ask you to do a Dix-Hallpike and a supine roll test. The first one, Dix-Hallpike, a test for posterior canal, BPPV, and the second one, a test for horizontal canal, BPPV. And they actually put the eponym, the Pagnini-McClure, but I prefer to call it the supine roll test. So positional nystagmus really is going to be a historical thing. It's going to be, oh yeah, every time I get out of bed and roll over, I get this horrible wave of vertigo and then it goes away and I'm fine otherwise. Or when I put my head in these extreme positions, you probably won't see any nystagmus in the actual discussion with the patient in your initial exam. It's really, they historically will endorse it. And then you do these provocative tests to actually see if you could recreate that movement that will generate the nystagmus. If they have spontaneous nystagmus, meaning that they have it while just sitting there or while pushing their gaze to either side 30 degrees, then they're going to ask you, is it pluridirectional is the word they use. We call it bidirectional in our course. Pluridirectional means when you look to the left, it beats fast left. If you look to the right, it beats fast. That should scare you. That gets a workup for central vertigo. If it's unidirectional, then you're going to do a head impulse test, part of the HINTS exam. And the head impulse test, and this is always confusing, so we actually, instead of calling it negative and positive like they do in the standing protocol, because negative is bad and positive is good, because positive is what you expect with vestibular neuritis, we call it central and peripheral. So if you have a central result, then obviously you get worked up for central vertigo. If you have a peripheral result, then we are going to walk you, all right? And so we will walk the patient, and if they're unable to stand or walk without aid, then again, we'll work them up for central vertigo. If they are able to walk without aid, even with that slightly ataxic gait, then we're going to say they're vestibular neuritis. All right. If we go back up to the top and there was no nystagmus, what they should say, and they don't in the standing protocol, this is the first problem with it, but they do remedy it in a future iteration, is does the patient have any gait abnormality? They still have in their original protocol the unable to stand or walk autonomously. That's not right. Now, if they have a positive Dix-Hallpike or a positive supine roll test, then you'll diagnose them with BPPV. They don't talk about anterior canal, but that's okay. It's fairly rare. That's really for vertigo experts. And then hopefully what you will do is you first test their gait just to make sure, though at that point you should be pretty reassured that the patient has a benign cause. And then you probably should do the curative maneuvers for each of either the posterior canal or horizontal canal. So standing's pretty good. It puts you into an algorithm. But what it doesn't do is relieve the necessity of actually understanding how to do all those things. So now you know how to assess for nystagmus, you know how to do a Dix-Hallpike, you know how to do a supine roll test, you know how to do a head impulse test, you know how to look for bidirectional nystagmus. If you know all that stuff, do you really need a protocol anymore? You don't. But the problem is, I don't think many people know all the pieces of the standing protocol, how to actually do those things. And as a result, then having the protocol doesn't help. Now, there's some further problems with the standing protocol. First of all, the Fresnel lenses. No one has them in the States. And even if you do have them in your shop, allegedly, they're much akin to the tono pen. It's variable whether they're going to be working or present or in the drawer when you need them or not. When I've spoken to people who have designed the standing protocol, they say, no, you can get away without it. And we teach you in our Vertigo course how to eliminate fixation, which I think is the major benefit of the Fresnel lenses, just using a piece of paper. So you don't need them. So that's not a big problem. All right. Next up, they leave out the test of skew, which is a way of seeing vertical malalignment of the patient's eyes that also would be indicative of a central cause. That's part of the HINTS exam, and they left it out. I don't know why. It's not a hard exam. The hardest part of the HINTS exam is the head impulse test, which they left in appropriately. But the test of skew is not that hard. You got to learn how to do it, but once you learn, it's not one that requires a ton of skill to continue to recollect. So I'm not sure why they left that out. But what was low-hanging fruit, and certainly should have been a part of the standing protocol, I don't know why it's not, is what takes the HINTS exam and makes it the HINTS Plus. And what makes the HINTS exam HINTS Plus is a quick test of hearing. And we're not talking audiometry. We're talking rubbing your fingers on one ear and then on the other and asking if they sound the same. That will pick up ICA strokes, and you should be doing this on all of your vertigo patients that you're screening for central cause. There's no reason to leave that out. It's like I said, it's low-hanging fruit. It takes 2 seconds and doesn't require any training. The next thing that the standing protocol is problematic for, it eliminates the spontaneous episodic dizziness. And this is a bunch of your patients are going to be presenting with this. This is the category that encompasses things like vestibular migraine. It encompasses the atypical presentation of BPPV. It encompasses rarely posterior TIAs. So really you should understand that. Like that's something that takes you from dizzy competent to dizzy mastery, as Peter Johns likes to say. So we have that in our course and in my flowchart protocol because you got to know it. It's just part of good dizziness management in the emergency department or the clinics. And then, as I mentioned, they have the walking incorrect in their original protocol. Now, a new paper was published called Standing-M, which fixes the gait issue. The problem is that I can't find a single new image of their protocol that actually encompasses that fixing of the gait. So everything out there has the wrong stuff on gait. I made my own. I altered the standing protocol diagram with the proper gait stuff. So it now has an asterisk that says if nystagmus is absent, then any gait abnormality from baseline should prompt a workup for central vertigo. So that fixes it. The Standing-M paper achieved a sensitivity of 88% and a specificity of 91%. Not too bad at all. Negative predictive value, 99%. So it's a good protocol, but it's an unnecessary protocol. If you know all the stuff that are part of it, if you learned all of those things, you understand dizziness. And if you understand dizziness, you don't need a protocol anymore. So it is not obviating a dizziness skill set. And if you have a dizziness skill set, it obviates the necessity of the standing protocol, in my estimation. So we went over Sudbury, not good, not safe. We went over standing, pretty damn good, but probably unnecessary, and missing some low-hanging fruit. So what do I think you should do? Now, I'd be remiss if I didn't put in a very brief plug for the course that I keep mentioning because it solves all of the problems. As soon as you understand dizziness, which I didn't throughout the entire course of my residency and the beginning of my attending life. It wasn't until I discovered Peter Johns and some of the other brilliant educators in vertigo world, like David Newman Toker and others, that I really started understanding dizziness and vertigo. And I was probably still performing better than most because I would do Dix-Hallpike tests and Epley. But the way I was taught in residency, it was simply, did it actually reproduce the patient's symptoms when I did a Dix-Hallpike test? And if it did, then I would do an Epley. But I wasn't even looking at the patient's eyes. And even if I did, I wouldn't have known what to look for. And as a result, I was probably missing things like horizontal canal BPPV, which is not going to be cured by an Epley maneuver, or anterior canal. And scarily, in a very small percentage, I was probably had the potential to miss a CPV patient, a central cause of positional vertigo. So that alone was an enormous jump forward. But then learning how to do the proper technique for the HINTS Plus exam, learning all of the causes of spontaneous episodic dizziness and diagnosing things like vestibular migraine made me a much better practitioner. You could have that same opportunity by taking the SPIN class. The SPIN class is our vertigo and dizziness mastery class. This took 2 years. I got the best educator I could find, Peter Johns, on vertigo and dizziness. And then I used whatever little talent I have to actually organize all of the information and put it in an easily assimilable form that you will be able after the course. And it's a brief course. It'll take you probably 6 or 8 hours. Once you're done, that's it. You're like done with dizziness. And there's a cheat sheet and a flow chart and videos and demonstrations and assessments of skill, everything you need that by the time you're done, it's like, oh, why didn't they teach me that in residency? What the hell? Well, I feel like something was stolen from me by not getting this course in residency because this is what they were supposed to teach us as an emergency doc or a physical therapist dealing with vertigo issues or an ENT doc or anyone who touches vertigo and dizziness. This is the course for you. Now, why am I wasting your time advertising it? Because I'm going to give you a free video chapter. So you will actually be able to see Peter talk about the pitfalls of the HINTS exam fantastic unit. And you can just get it for free and watch it and say, oh, wow, I want more of this, or I never want to see this again. So if you want that, just go either to the show notes and click on the link, or if you're just listening and you don't want to go to the website, just go to vertigocourse.com. That's vertigocourse.com. Go there, and then you won't need a Sudbury risk score, and you shouldn't want it. You won't need a standing protocol, even though it's pretty good. You won't need it anymore. You'll understand it. You'll never need another protocol. And you'll be able to go from vertigo competence to mastery and diagnose things like vestibular migraine, posterior TIA, and all of the other subtle diagnoses that you will not get from any of these protocols. All right, so there's the EMCrit We. Scott Weingart from the EMCrit podcast saying bye-bye. As always, promote dignity, relief, and warmth. Very rapidly, some current projects you may be interested in. The Awake and Aware Conference, Scottsdale, Arizona, February 2027. Its Kickstarter has sold out, so the conference is live. Unfortunately, you missed the super discounted tickets, but the full price tickets are now available, and I will tell you the link at the end of this discussion. But that conference was amazing last year. It will be amazing this year. The Out on Time course, it is our charting course, our malpractice avoidance course, our getting out on time course, feeling on top of your shift efficiency. The spin class, that is our vertigo and dizziness mastery class. It is to get you to the point where you will be eager rather than dreading picking up a dizziness chart. We have the Resus Leadership Academy. That is our online fellowship to take you from emergency medicine or hospitalist to aggressively potent resuscitation doctor. You will be the person in your department leading the game on resuscitation and acute critical care. The Unburnable course, that is our burnout prevention course, our finding joy and flourishing in your career course. That is a cohort online course, so it is done in real time, and it has been lovely. This is our 5th cohort. And then, last but not least, the Reanimate course. That is our eCPR, ECMO CPR, and resuscitative ECMO course. It sells out every year. If you want to come, the time to buy tickets is now, because every year I get people, 4 months before the conference, they're like, I really want to come. Well, guess what? You can't, because I told you for the 5 months before now that they sell out every single year. You should have listened. So if you want to check out any of that stuff, come to emcrit.org/stuff. emcrit.org/stuff. That's emcrit.org/STUFF. So I've loved talking to you. I'll talk to you again soon. Scott Weingart saying bye-bye.